So good afternoon, friends. Can you hear my voice clearly? Can you hear my voice clearly? So are you able to hear my voice clearly? We are going to discuss about skeletal muscle relaxant. Are you able to hear my voice clearly? Okay, we start with this next muscle relaxant. So in muscle system, only one topic in pharmacology is there, that is relaxant, muscle relaxants, what we call. So skeletal muscle relaxants are the drugs. We select the pointer. These are the drugs that act peripherally at neuromuscular junction. So remember the site of action of the drug, that is neuromuscular junction. The primary intention of this drug is to relax the skeletal muscle fiber, skeletal muscle. So to relax the skeletal muscle fiber, this drug should act at the neuromuscular junction and neuromuscular junction, or as well as the muscle fiber itself. So there are two sides of action. One is neuromuscular junction and second is muscle fiber itself. Apart from once it will be on the central, also the muscle relaxants of the relaxants, peripheral muscle relaxant and peripheral muscle relaxant. Peripheral muscle relaxant, the muscles are neural junction or at fiber itself. So central can activate cell and to reduce the bone. Central cell, it reduces the muscle tone and it may cause temporary or permanent paralysis. So the drugs which are used in anesthesia as well as for treatment purpose, they are causing permanent. Understood the basic of the skeletal muscle relaxant. There are two types of action, mainly peripheral and central. In peripheral, they are working either at the either at the muscle fiber level or at the neuromuscular junction level, and in central, it is working over the cerebrospinal axis, that is over the CNS, reduce the muscle tone and it may cause paralysis. So muscle relaxant drug that affect the skeletal muscle function, it can affect the skeletal muscle function and decrease the muscle tone. So primarily it decrease muscle tone and it may be used to improve the symptoms such as muscle spasm. It is used in case of the muscle spasm, pain, as well as hyperreflexia. So these are the drugs which are used in case of the relief of the muscle spasm, pain, and hyperreflexia. So first of all, peripherally acting skeletal muscle relaxants. We are going to talk about peripherally acting skeletal muscle relaxant. As you know that basically there are two types, peripheral skeletal muscle relaxant and central skeletal muscle relaxant. See friends, we are going very slowly with understanding of the things. So if you pay proper attention over the lecture, you can remember so many things. So in peripheral skeletal muscle relaxant, these drugs are called as neuromuscular blocking agent. Neuromuscular blocking agent. Now tell me, why these drugs are called as neuromuscular blocking agent? Why these drugs are called neuromuscular blocking agent? Some students are saying that voice is getting chopped in between. Voice is not clear. Currently, I am facing since last 10 minutes. Since last 10 minutes, I am facing connectivity problem. So because of the connectivity problem, it may be there. Now, is voice clear and audible? Is voice clear and audible? I have asked the question why these peripheral muscle relaxants are also called neuromuscular blocking agent. The answer is itself in previous explanation. Is my voice clear and audible? Is my voice clear and audible? Okay, some of the students are saying yes. So because site of, yes, I am getting reply, because site of the action is neuromuscular junction. Very good. So you have understood the previous slide very well, because it is acting on the neuromuscular junction. Yes, I am getting reply from some of the student. So in between, if the voice is choppy, there is connectivity problem for some duration. So we will be continuing with this. So we will finish this topic. Whatever the problems are there, we will finish this topic today. And for tomorrow also, we will be meeting at 6 p.m. Said tomorrow is Saturday, and I think it will be comfortable to all of you to meet at 6 p.m. After getting up from the bed after afternoon sleep. I think it is the okay time, 6 p.m. So in these are the drugs which are neuromuscular blocking agent. So in neuromuscular blocking agent, there are two types again: non-depolarizing blockers, or they are also called as competitive blocker. Non-depolarizing blocker or competitive blocker, and there are second type of the drug. These are depolarizing blocker. Depolarizing blocker. Again, in non-depolarizing blocker, there are long-acting, intermediate acting, and short acting drugs. So neuromuscular blocking agents are of two types: non-depolarizing blockers or competitive blocker. Remember this name also well, competitive blocker, because the name itself suggests its mechanism of action, competitive blocker. And second is depolarizing blocker. In non-depolarizing blocker also there are three types: long acting, intermediate acting, and I think now everybody is online. Is it visible and audible? Is it visible and audible to all of you? Mhm. Is it visible and audible to all of you? Now, I think audible now. Now audible and visible also. I think now. Okay, so I have kept classification of the peripherally acting muscle relaxant in front of you. Try to go through this classification again and try to remember the names. Again, I am reading non-depolarizing blocker and depolarizing blocker. In non-depolarizing blocker, there are three types: long-acting, intermediate-acting, and short-acting. And in long-acting, there is D-tubocurine, pancuronium, doxapuronium, pipecuronium. In intermediate acting, becuronium, atracurium, cisatracurium, rocuronium, and rapacuronium. In short acting, mivacurium, and in depolarizing blocker, succinylcholine. So try to remember the names. Try to remember the names right now. Inform your other colleague that we have again started. We have again started. Inform your other colleague that we have again started. Try to remember the names. I am keeping this slide in front of you for 1 to 2 minutes. Try to remember the names of skeletal muscle relaxants. Inform your colleague that we have again started. Those who have joined right now, I am keeping this slide in front of you. Names of neuromuscular blocking agent, and try to remember these names. Two types: non-depolarizing, depolarizing. In non-depolarizing, long-acting, intermediate-acting, short-acting. First, remember short-acting, only one, mivacurium. Then long-acting, DTC, ditibocurine, pancuronium, pipecuronium, pan and pipe, and doxa, pan, pipe, and doxa. In intermediate, vacuronium, atracurium, cisatracurium, rocuronium, and rapacuronium. And in depolarizing blocker, succinylcholine. I'm giving you 1 more minute. 1 more minute to remember. Inform your other colleague that we have again started, and it is, I think, going on smoothly now. Inform your other colleagues that we have again started. We have again started and it is going on smoothly now. And you are all trying to remember the names of neuromuscular blocking agent. Jamin saying, set the link. Thank you. Okay. So write down the names as much as you remember in chat box. As many as names possible you remember, write down in chat box. Write down in chat box as many names as possible. We have gone through neuromuscular blocking agents. What are neuromuscular blocking agents? Write down the names. Okay, I'm getting reply. Pancuronium, then long-acting is DTC, pancuronium, doxycycline, very good. Pancuronium again. Then doxycycline. Okay, rapacuronium, succinyl choline. I'm getting reply from so many students. Very good. Yes, very nice. Depolarizing blocker. So you have. Okay, we are now moving further. So first of all, we are talking about non-depolarizing or competitive blocker. Let me select this pointer again. So depolarizing, competitive blocker. You remember that there are three types again in competitive blocker: long-acting, intermediate acting, and short-acting. So first of all, mechanism of action. As you know, that is these are the competitive blocker. So it blocks something. It is blocking something. What it is blocking? It is blocking this skeletal muscle activity. How? By blocking activity at the neuromuscular junction or at the nerve fiber. Which activity? Nerve muscle transmission of the impulse. It is blocking impulse transmission. Yes, you know that basic physiology. When muscle gets relaxed, whenever the impulse transmission in the muscle is blocked, muscle gets relaxed. So the site of action of the both competitive and depolarizing blocker is the end plate of skeletal muscle fiber. You know that very well. You have learned in physiology. So by blocking this end plate activity, by blocking that end plate activity, skeletal muscle relaxation, it is muscle fiber. So pharmacological action, skeletal muscle, intravenous injection of the non-depolarizing blocker rapidly produce muscle weakness. First of all, muscle weakness followed by flaccid paralysis, but this is temporary. So non-depolarizing blocker, it produces first of all muscle weakness followed by flaccid paralysis. How? On intravenous injection. So we need to give this intravenous injection while performing surgery. So during surgery, along with anesthesia, this skeletal muscle relaxants are given to relax skeletal muscle so that the dose of anesthesia needed is very less and surgery can be performed easily. So first of action is on skeletal muscle. Then second action is on autonomic ganglia. It produces some degree of ganglion blockage. So in muscle weakness and flaccid paralysis. In ganglia, ganglion blockage. Third action is on histamine release. So DTC produce histamine release from mast cell or mast cells. So histamine release contributes to the hypotension. Because of the histamine, there will be hypotension and flushing as well as bronchospasm and increase respiratory secretion. So these are all side effects. And this we consider as the side effect of the skeletal muscle relaxation. Because of the histamine release, there is flushing, there is bronchospasm, increased respiratory secretion, and hypotension. So until now, we have discussed action on skeletal muscle, autonomic ganglia, and histamine. Then on cardiovascular system, DTC produce significant fall in blood pressure. This is because of ganglion blockage, histamine release, and reduced venous return. Remember, in histamine release also we have seen that there is hypotension. Because of the DTC, there is histamine release, and histamine release leads to hypotension. So Pauling BP is because of three actions: ganglion blockage, histamine release, and reduced venous return. Then on GIT, second action is on GIT. It block ganglion blocking activity of the competitive blocker may enhance post-operative paralytic ileus after abdominal operation. So this is another side effect. Post-operative, that is after surgery. Paralytic ileus means ileum become paralytic. Ileum is also composed of muscle. Here it is smooth muscle. So because of this muscle relaxation, ileum may become paralyzed, and that is called as post-operative paralytic ileus, because we are giving this anesthetic, this skeletal muscle relaxant along with the anesthetic during the surgery. So in abdominal surgery, it can be the side effect. In central nervous system, all neuromuscular blockers are contrary compound. They do not cross blood-brain barrier, do not cross BBB. So there is no effect on central nervous system. So this were the general actions of non-depolarizing blockers on skeletal muscle, on autonomic ganglia, histamine release, cardiovascular system, GIT, and central nervous system. So go through these slides again. Actions of this competitive blocker. I am trying that your skeletal muscle relaxant gets prepared right now. Go through these slides and try to remember actions: skeletal muscle relaxant, autonomic ganglia, histamine release. It's very easy. On skeletal muscle relaxant, muscle weakness followed by paralysis, autonomic ganglia, ganglion blockage, histamine release. Because of histamine release, there is hypotension. Histamine is released from mast cell. Hypotension, flushing, bronchospasm, increased respiratory secretion. In cardiovascular system, fall in BP because of the three effects: ganglion blockage, histamine release, and reduced venous return. And in GIT, there is post-operative paralytic ileus. And CNS, they do not cross blood-brain barrier, so no effect. So try to remember this. So I'm getting question from Jamin, sir, if they can't cross blood-brain barrier, can we introduce them directly via central nervous route? No, we cannot give them centrally, because it is going to damage central nervous system. We can only give through blood. We have to produce action over the nerve muscle end plate, over the neuromuscular junction. If we give them into the CNS, through the CSF, it is not going to be circulated through the muscle end plate, and it is not going to produce the desired effect, and it will going to produce adverse effect on the CNS. So only established route is through injection, which is bearing this blood-brain barrier. Okay, I think you have remembered the actions. So write down in chat box. Write down in chat box whatever the actions you remember. Write down in chat box. Some students may have started writing. I think as you have predicted that sir is going to ask the write down in chat box. So while reading, you have started writing. I think as soon as sir asks, we will just click the send button. Yes, I'm getting reply. Skeletal muscle, it will produce, or acid paralysis, ganglion blockage, histamine release, hypotension. Yes, very good. So I'm getting fast reply. Fall in blood pressure, muscle weakness, flaccid paralysis, hypotension, fall in blood pressure, postoperative paralytic ileus, ganglion blockage. I think you all have kept ready answer. Very nice. But try to remember this. Our our basic objective is that you understand and then remember. In yes, hypotension, in GIT, postoperative paralytic ileus, very good. Okay, we are moving now further. Non-depolarizing blocker, individual compound. You have seen that there are variety of the non-depolarizing blockers. So first of all, D-tibocurine, not clinically used due to its histaminic effect. DTC, remember that in histaminic effects are because of DTC. Here it is. DTC release histamine. Yeah, you have seen that histamine release is because of DTC, that is D-tibocurine. So because of this, D-tibocurine is not used clinically. It is not used clinically. Then you may be asking, sir, why are you teaching us this D-tibocurine? It is important to know. So in pharmacology and medicine, what is not used and why this is not used, why that is not being carried out, why this activity or why this action is not important clinically, that should be also known, so that we can take care of that while in our practice. So DTC is not used. Succinylcholine is most commonly used muscle relaxant for passing tracheal tube. It induces rapid, complete, and predictable paralysis with spontaneous recovery in 5 minutes. So muscle paralysis is produced and spontaneous recovery within 5 minutes. So it is short acting. It is short acting. It is used in short procedure like passing the tracheal tube while performing this bronchoscopy. Occasionally, succinylcholine is used by continuous IV infusion for producing controlled muscle relaxation for longer time. As we have seen that succinylcholine is acting for very short period of time, that is for 5 minutes. But if we want to prolong the action of the succinylcholine, we can use controlled IV infusion. By giving continuous IV infusion, we can produce for longer duration, but it is to be taken care that the paralysis should not be lasting longer, for more longer time. It should be avoided in younger children unless absolutely necessary. So in young children we cannot give because there is risk of hypokalemia and cardiac arrhythmia. In young children, it may produce cardiac arrhythmia and hypokalemia. So succinylcholine is not used. So it is, remember, in succinylcholine, duration of action that is very short. Recovery is within 5 minutes. If we want to prolong this action, we can use continuous IV infusion. But again, we should take care that it's not used for more than some minutes. Then in young children, it is to be avoided because there is risk of hyperkalemia and cardiac arrhythmia. Another is pancuronium. It is synthetic steroidal compound and 5 times more potent and longer acting than DTC. It is longer acting than DTC. Because of the longer duration of the action, needing reversal, its use is now restricted to prolonged operations, especially neurosurgery. So pancuronium is used in neurosurgery. Neurosurgery, they are taking hours, for 3 to 2 hours, 4 5 hours, depending upon the type of the neurosurgery. We have to open in case the neurosurgeon opens the brain and perform neurosurgery. So neurosurgery is taking longer time. So for longer duration of the action, the skeletal muscle relaxant, which is having the longer duration of action, like pancuronium, it can be used. Pipecuronium, that is the muscle relaxant with the slow onset and long duration. Again, it is having the long duration of action, steroidal in nature. So both pancuronium and pipecuronium, these are steroidal. These are steroidal in nature and recommended for prolonged surgery. Again, same example, neurosurgery. So pancuronium and pipecuronium, remember, these are for prolonged surgery. The drugs like succinylcholine is for short surgery. Then vacuum, most commonly used skeletal muscle relaxant for routine surgery, and in intensive care unit, ICU. You may have heard the word ICU frequently nowadays in case of the corona. So vacuronium is used in case of the ICU and in case of the routine surgery. So atracurium, it is 4 times less potent than the pancuronium and shorter acting. Rocuronium, There is a muscle relaxant with the rapid onset and intermediate duration of the action, which can be used alternative to the succinylcholine for tracheal intubation. So in tracheal intubation, succinylcholine as well as this rocuronium can be used. It is also shorter acting without disadvantage of the this depolarizing block or cardiovascular changes. So again, I repeat this slide. Rocuronium, it is used in ICU for routine surgery. Most commonly, remember this is the most commonly used skeletal muscle relaxant for routine surgery. For routine surgery, rocuronium is used. Atracurium, short acting. Rocuronium, it is alternative to succinylcholine in depolarizing block and in cardiovascular changes. So try to remember this. Again, I am giving you 3-4 minutes for these slides. DTC, non-clinically used because of the histaminic effect. Succinylcholine, most commonly used muscle relaxant for passing tracheal tube. In this condition, it is most commonly used. Recovery in 5 minutes. If we want to use for prolonged period, continuous IV infusion can be given. Avoided in young children because of risk of hyperkalemia and cardiac arrhythmia. Then pancuronium, steroidal. Pancuronium and pipacuronium both are steroidal. Is S for steroidal. Pancuronium is long acting. It is written in classification itself. You can correlate this classification. Remember in classification, long acting, pancuronium, pipacuronium. That is okay. Intermediate acting, atracurium, and this is atracurium. Rocuronium, rapacuronium. Short acting is myvacurium. Pancuronium is used for because of the longer duration, prolonged surgery, especially neurosurgery. Pipacuronium is also for prolonged surgery. So pancuronium and this pipacuronium, these are for prolonged surgery because of long duration of the action. Rocuronium in surgery and in ICU, most commonly used muscle relaxant. Atracurium, shorter acting. Rocuronium, alternative succinylcholine in tracheal intubation. Okay, we are moving further. Non-depolarizing blocker, individual compound, that is continuing. So their uses now uses. Some of the uses we have also discussed it. That is neurosurgery. Most common, it's used in adjuvant to general anesthesia. Adjuvant to general anesthesia. So neuromuscular blockers are important in general anesthesia. These are the choice of neuromuscular blocker. It depends upon the duration of the procedure. We have seen previously that for longer surgery, the neuromuscular blockers having the long duration of the action, like pancuronium, this pipacuronium, they can be used, like in case of the neurosurgery. For short surgery, for short procedure, like in case of the tracheal intubation, succinylcholine can be used. So rocuronium, these are the most frequently selected non-depolarizing blocker. Rocuronium and rocuronium. Previously, it is also there mentioned. Rocuronium. So most commonly used this non-depolarizing blocker are rocuronium and rocuronium. So most importantly, only one use. Main use is only one. That is in general anesthesia. This muscle relaxants are used. Assisted ventilation is second use in critically ill patient in ICU. Often it is ventilatory support is needed. You may have heard frequently this word ventilator nowadays because of the corona. So to give ventilation in critically ill patient, often along with the ventilation. Another use, convulsion and trauma. So these are also used in case of to prevent the convulsion and trauma. So in trauma also to relax the muscle, but it is less commonly used. Assisted ventilation, it is already written over here. Second time it is written. So that is the use. Mainly use is during surgery. During surgery, these non-depolarizing blocker are used most commonly rocuronium. Now Directly acting muscle relaxant, another class of the drug, directly acting muscle relaxant. In that, you have to remember this name, dantrolene. It acts on this receptor RYR1, that is ryanodine receptor calcium channel in the sarcoplasmic reticulum of the skeletal muscle and prevent calcium induced calcium release through sarcoplasmic reticulum. So it is very easy to remember. It basically acts on the calcium channel. It acts on the calcium channel and it prevents calcium release. As you know that for the muscle contraction, calcium release is important. So if the drug like dantrolene, if it decrease calcium release from the SR, sarcoplasmic reticulum, muscle is going to relax. It is very simple. So again, you remember this, dantrolene acts on the RYR1, that is ryanodine receptor calcium channel in SR, sarcoplasmic reticulum of the skeletal muscle, and prevents calcium induced calcium release. See, this is the tricky word, calcium induced calcium release. As you know that the calcium itself induced calcium release from sarcoplasmic reticulum. Calcium itself is the triggering factor for the release of the calcium from the sarcoplasmic reticulum. So this dantrolene decrease this calcium induced calcium release, and through it will be leading to relaxation of the skeletal muscle. So dantrolene is slowly but adequately absorbed from the GIT, it penetrates brain and produce some sedation. This is pharmacokinetic, so we are not discussing about the pharmacokinetic. So difference between centrally acting and peripherally acting skeletal muscle. So first difference is centrally acting skeletal muscle relaxant, it decreases muscle tone without reducing voluntary power. It decreases muscle tone, but voluntary power of the muscle is not reduced. It peripherally acting, we have seen peripherally acting, it causes muscle paralysis. So as you know, whenever the term paralysis is used, voluntary movement is lost. So that is the first difference, voluntary movement. Centrally acting selectively inhibit polysynaptic reflex in CNS. It inhibit the reflex in polysynaptic reflex in CNS, while here it block neuromuscular transmission. Then centrally acting cause some CNS depression. Remember that some of the student has asked that can we give this peripherally acting muscle relaxant in CNS? See, centrally acting, they are also causing CNS depression. But peripherally acting has no effect on CNS. Why? We have discussed, it cannot cross blood-brain barrier. Centrally acting can be given orally and sometimes parenterally. Peripherally acting, they are always given IV. And centrally acting are used in chronic spastic condition, acute muscle spasm, and tetanus. While this is used for surgical operation, only and only use of peripherally acting muscle relaxant is during surgery. So these are the difference 1, 2, 3, and 4. This is the difference of centrally acting and peripherally acting. Centrally acting, the name we are going to discuss in next slide. Just remember the difference. Again, I am repeating, and along with me, try to remember the things. Centrally acting, they are decreasing muscle tone without reducing muscle power. They are peripherally causing muscle paralysis, and muscle movement also lost. Muscle power is lost. Selectively inhibit polysynaptic reflex, they block neurotransmission. Here they inhibit polysynaptic reflex in CNS. Centrally acting are acting on the CNS. So they are inhibiting the polysynaptic reflex in CNS. They are blocking the neuromuscular transmission. As CNS depression, it's no effect on the CNS. This is third actually. This is fourth, and this is fifth. They can be orally, sometimes parenterally, always given and used in chronic spastic condition, acute muscle spasm, and tetanus. They are peripherally acting are used during surgical operations. So I'm keeping this slide in front of you. Try to remember the difference between centrally acting and peripherally acting muscle relaxants. Try to remember the difference between these two, centrally acting and peripherally acting muscle relaxants. See, one more thing, that whatever the lecture we have taken on YouTube Live, they are persisting in YouTube channel for lifelong. They are persisting forever, so you can hear anytime. You can revise anytime. These lectures, whatever the lecture we have previously taken, they are also there in YouTube channel in Medical Mahatma. So they are persisting forever. So you can revise them. So I think you have gone through this difference. Okay, write down the difference in chat box. Write down in chat box. Write down this difference in chat box. Difference between centrally acting and peripherally acting muscle relaxants. Okay, write down the difference between centrally and peripherally acting muscle relaxant in chat box. Centrally acting cause CNS depression, centrally cause CNS depression, peripherally no effect on the CNS, very nice. Centrally are used for chronic spastic conditions. Centrally acting inhibit the polysynaptic reflex and peripherally block neuromuscular junction, very nice. Centrally are acting, they are given orally. Peripherally acting, no effect on CNS. Centrally given for spasm and peripherally for paralysis, very nice. All students, Nidhi, Raksava, Prinkle, Jaimin, Janvi, Hasti, Nupur. Everybody has answered. Nancy, everybody has answered. Janvi, Manali. Okay, very nice. Jaimin, centrally acting given orally or peripherally acting given IV. Very nice. Peripherally IV, yes. Okay. So we are now going to see the names of the centrally acting muscle relaxant. So class and example, you can remember directly. Example, or I think class, by class you can remember easily. Mephanacin congener or mephanacin itself. Mephanacin itself, whatever the muscle relaxant I am giving the tick mark, that you can remember. Chlorzoxazone, that muscle relaxant you will be using frequently. You may have consumed this muscle relaxant also. This is given in routine treatment. Apart from the surgery, these are given in routine treatment. Whenever we feel muscle pain, because of the muscular activity, this chlorzoxazone is most commonly used. I have taken this many times. Chlorzoxazone. One drug name is there. In market it is available as DAN MR, DAN MR. So MR is muscle relaxant. MR stands for muscle relaxant. In MR, this chlorzoxazone is there, and DAN, that is diclofenac. Diclofenac and muscle chlorzoxazone combination drug is available whenever the pain is arising out of the muscle. to relax the muscle. This is given. So mephenacin and chlorzoxazone, these two you can remember. Benzodiazepine are diazepam and others, and GABA-mimetic are baclofen. This baclofen is also available in many combinations, baclofen and this tizanidine. So basically 4 drugs: mephenacin, chlorzoxazone, these 5 drugs. Sorry, mephenacin, chlorzoxazone, diazepam, baclofen, and this tizanidine. You can remember these names. These are muscle relaxant. Diazepam, if you remember the diazepam, this is also there in benzodiazepine. We have discussed the chapter of the benzodiazepine. In that, it is used as the drug is used in various purposes, like in case of the insomnia for sedation, can be used. In case of you can remember these names over here also. In centrally acting muscle relaxant, you can remember the name of the diazepam also. In convulsion also diazepam is used. In case of the convulsion, IV diazepam is used. We have discussed this also in that also. Mephenacin, chlorzoxazone, diazepam, baclofen, and tizanidine. Okay, so baclofen, that is the analog of the inhibitory transmitter GABA. This analog of the GABA is gamma aminobutyric acid. So it is selectively acting on the GABA B receptor. It is GABA B receptor agonist. It is GABA B receptor agonist. Primary site of the action of the baclofen is in spinal cord. Remember, we are discussing central acting muscle reaction. The primary site of the action is spinal cord, where it causes depression of the postsynaptic and monosynaptic reflex. So baclofen causes depression of the postsynaptic and monosynaptic reflex by acting on the GABA. It's as such, it does produce muscle weakness and less sedative action than diazepam. So diazepam is having the sedative action, but baclofen is having less sedative action. It is well absorbed orally. This is pharmacokinetic, so no need to remember this pharmacokinetic. So basically, you remember that it is selectively acting on GABA receptor. It is agonist at the GABA receptor. Primary site of the action is in spinal cord, where it depresses polysynaptic and monosynaptic reflex. Side effect of baclofen are drowsiness, mental confusion, then this weakness and ataxia. Serum transaminase level may rise, and sudden withdrawal of the baclofen after chronic use may produce hallucination, tachycardia, and seizure. That is after the sudden withdrawal of this baclofen. Tizanidine, that is also clonidine congener. It is centrally acting alpha-2 agonist. Remember, this we have discussed in case of the anti-hypertensive drug clonidine and methyl dopa. If you remember, methyl dopa and clonidine, these are both centrally acting alpha-2 receptor agonists, which are used, particularly this methyl dopa is used in hypertension during pregnancy. So tizanidine, the name nidine, here it is also nidine. So clonidine and tizanidine, these are similar. This is clonidine congener and acting on the central alpha-2 receptor agonist, inhibit the release of the excitatory amino acid in spinal neuron. Excitatory amino acid in spinal neuron. So it may facilitate the inhibitory neurotransmitter glycine as well. So one student has asked that the drugs which are there in peripherally acting muscle relaxant, can it be given in central through central route directly CSF? See here also this. They are also given orally. Remember, they are given also around CS. So these are centrally acting alpha-2 receptor, alpha-2 adrenergic agonist. Side effects are dry mouth, drowsiness, nighttime insomnia, and hallucination. Of course, insomnia is nighttime. Dose-dependent elevation of the liver enzyme can occur. There is no consistent effect on the BP has been observed, and it should be avoided in patient receiving antihypertensive. So tizanidine, especially if any person is receiving clonidine, then it should be avoided because there is a variable effect on the blood pressure. Blood pressure may either fall or it may shoot up also. Generally, it will be falling. So it may cause hypotension. So it should be avoided in patient taking antihypertensive. Uses of centrally acting muscle relaxant: acute muscle spasm, torticollis, lumbo, backache, neuralgia. So problems which are related to CNS, anxiety and tension, spastic neurological disease, tetanus. During ECT, electroconvulsive therapy. See, this is the therapy which is used in psychiatry. ECT, electroconvulsive therapy. In simple words, we use that we are giving shock to the patient. So that is what electroconvulsive therapy. So during that part also, muscles of the patient should be relaxed. So the centrally acting muscle relaxants are given before giving ECT. And in orthopedic manipulation, during orthopedic procedure, suppose we have to repair the fracture, we have to repair the dislocation, particularly not repairing fracture, but during the dislocation repair, that is orthopedic manipulation. So muscle relaxant can be used. In that condition, centrally acting muscle relaxants are used. So acute spasm, particularly backache and neuralgia, anxiety and tension, spastic neurological conditions, tetanus, ECT, and orthopedic manipulation. These are the uses of centrally acting muscle relaxant. So that is all about muscle relaxant. Hope you have enjoyed this class. Tomorrow we will be meeting at 6 p.m. Tomorrow at 6 p.m. Till then, try to revise this class and give me also other topics which you want to learn from me. Otherwise, I will be doing myself. Whatever the topics are there, you can directly WhatsApp me. Whatever the topic has been taken or asked in previous 5 years question paper, or if according to your syllabus or according to you, if any topic is remaining, that you can WhatsApp me. Okay, thank you very much.